Watch one number, her urine output, hour by hour. 60 milliliters. Then 40. Then 25. Then 10. Her blood pressure is fine. Her heart rate is fine. Her temperature is fine. She is in this bed for something else entirely, and nothing else on this chart has changed. Only this one column, quietly falling. By the time the other numbers move, a lot of kidney is already gone. By the end of this, you will know why the urine falls first, whether the problem is in front of the kidney, inside it, or behind it, and what to do before the potassium climbs high enough to stop a heart. This is the kidney. All of it. Let's build it from the ground up. Chapter 1: The 6 Jobs. The working unit of the kidney is the nephron, and 1 million of them sit in each one. Blood enters a tiny tuft of capillaries called the glomerulus, and pressure pushes fluid out of the blood and into a tubule. That is filtration. Then, as the filtrate travels down the tubule, the body reclaims what it wants back, water, sodium, glucose, and secretes what it wants gone. What is left at the end is urine. Filter everything, reabsorb what you need, and let the rest go. That is the machine. Now the frame for the whole course. The kidney does 6 jobs, and every single finding in kidney failure is one of these 6 jobs not getting done. 1. It clears waste, so waste products build up. 2. It balances fluid, so fluid overloads. 3. It balances electrolytes, and the dangerous one is potassium. 4. It balances acid, so the blood turns acidic. 5. It helps control blood pressure through RAAS. 6. It makes erythropoietin, which tells the marrow to make red cells, and it activates vitamin D for the bones. 6 jobs. Memorize them, and you never memorize a symptom list again. And how do we measure how well the kidney is filtering? 2 labs, and they move together, up, as the kidney fails. Creatinine, a waste product from muscle that the kidney normally clears. And BUN, another waste product. When filtration drops, both rise. The truest measure is the GFR, the glomerular filtration rate, an estimate of how much blood the kidney filters each minute. High GFR is good. A low and falling GFR is the whole story of kidney disease. Our patient is a woman in her 50s, admitted for something unrelated. Her urine output has been falling for hours, and now her creatinine is starting to climb. One of her 6 jobs, clearing waste, is slipping. But before you can fix a failing kidney, you have to answer one question. And it is the question the exam cares about most. Is the problem in front of the kidney, inside it, or behind it? Chapter 2: When filtration fails. Acute kidney injury is a sudden drop in filtration, and it comes in exactly 3 flavors, sorted by where the problem is. Prerenal, the problem is in front of the kidney, not enough blood is getting there, from dehydration, blood loss, low blood pressure, or heart failure. The kidney itself is fine, it is just starved. Intrarenal, the problem is inside the kidney, actual damage to the tissue, most often acute tubular necrosis from prolonged low flow or from nephrotoxins. Postrenal, the problem is behind the kidney, an obstruction backing urine up, a stone, an enlarged prostate, a blocked catheter. Front, inside, behind, that is the entire classification. And the reason this matters more than the diagnosis is that the treatment is completely different for each. And the exam tests the classification. Prerenal, restore the flow, usually fluids, and treat the cause. Intrarenal, stop the nephrotoxin and support the kidney while it heals. Postrenal, relieve the obstruction and the kidney recovers on its own. Here is the trap. Giving fluid to a postrenal patient does nothing, the pipe is blocked downstream. And a prolonged prerenal problem, left unfixed, becomes an intrarenal one, because starved tissue eventually dies. Pause. A patient's urine output has dropped and the creatinine is rising. A bladder scan shows over 700 milliliters of retained urine. What type of AKI is this, and what is the priority? This is postrenal, AKI, and obstruction. The 700 milliliters sitting in the bladder is the clue. The urine is being made but cannot get out. The priority is to relieve the obstruction, insert or unblock the catheter, and the kidney recovers. The trap answer is a fluid bolus. Fluids do not help when the problem is a blocked pipe. Find where the problem is, then act. Our patient's bladder is empty, so it is not behind the kidney. Her problem is in front. She became dehydrated, and then she received a dose of a nephrotoxic drug. And prerenal is sliding toward intrarenal, the waste is building. And when the kidney stops clearing, one electrolyte climbs faster and more dangerously than all the others. Chapter 3: The Long Decline. Chronic kidney disease is the slow version, filtration declining over months and years, usually from diabetes and hypertension, the two leading causes. It is staged by the GFR, from stage 1, near normal, down to stage 5, kidney failure, where the GFR is under 15 and the patient needs dialysis or a transplant to live. And here is the useful part. As the GFR falls, the 6 jobs fail one by one, and the consequences stack up. So the stage does not just tell you a number, it tells you which problems to expect. Fuck the consequences, because each one is a job not getting done. Waste builds, so BUN and creatinine climb, and at the extreme, uremia, confusion and nausea and itching. Fluid overloads, so edema, hypertension, and pulmonary congestion. Potassium climbs. Acid builds, a metabolic acidosis. No erythropoietin, so anemia, which is why these patients are pale and exhausted. And no active vitamin D, so calcium falls and the bones weaken, renal bone disease. Every one of those is one of the 6 jobs, failing. Our patient is acute, not chronic, so with the right care her kidney can still recover. But right now, she has the same immediate danger a chronic patient in failure has. The electrolyte that does not wait. That is chapter 4, and it is the shortest and most important chapter in this course. Chapter 4: The Potassium Emergency. When the kidney stops clearing potassium, it climbs. And potassium is the electrolyte that stops hearts. This is the emergency in renal failure, the one that kills. As it rises, it destabilizes the electrical system of the heart, and it shows up on the ECG in a specific order. First, the T waves become tall and peaked. Then the P wave flattens and the QRS widens, and if it is not treated, the widening QRS slides into a lethal rhythm and the heart stops. A rising potassium in a renal patient is not a lab to note, it is a lab to act on. The treatment comes in 3 moves, in order of urgency. First, protect the heart. Intravenous calcium gluconate stabilizes the cardiac membrane immediately. It does not lower the potassium, it just buys time. And prevents the lethal rhythm. Second, shift the potassium into the cells, temporarily, with insulin given with glucose, and sometimes a breathing treatment. Third, actually remove it from the body, with a binder that pulls it into the stool or with dialysis. Protect, shift, remove. And the calcium is first because it is the one that keeps the heart beating while the others work. Pause and put these in order. A renal patient has a potassium of 6.8 with peak T waves on the monitor. Put the interventions in the order they should happen. Give intravenous calcium gluconate first, to stabilize the heart and prevent a lethal rhythm. Then give insulin with glucose to shift the potassium into the cells. Then give a binder, or arrange dialysis, to actually remove it. And keep the patient on continuous cardiac monitoring throughout. The classic error is reaching for the binder first. That removes potassium, but too slowly to protect a heart that is already showing changes. Protect the heart first. Our patient's potassium reached 6.2 with early peaked T waves. She got calcium to protect her heart, insulin and glucose to shift it, and a binder to remove it, and the rhythm settled. Her kidney is recovering. But some patients do not recover, and when the kidneys fail for good, another machine has to do their job. That is Chapter 5. Chapter 5: Dialysis. Dialysis does the kidney's cleaning job from outside the body, and there are 2 ways. Hemodialysis pulls the blood out, runs it through a machine that filters it against a clean solution called dialysate, and returns it, usually 3 times a week at a center. It is fast and efficient, but it needs access to a large blood flow, and it causes big fluid and electrolyte shifts each session. Peritoneal dialysis uses the lining of the patient's own abdomen as the filter. Dialysate is run into the belly, left to dwell while it pulls waste across the membrane, and then drained. It is slower and gentler, and the patient can do it at home. Hemodialysis needs access, and the best access is an AV fistula, an artery surgically joined to a vein in the arm, which over weeks becomes a strong vessel that can handle the flow. And this fistula comes with the single most tested rule in renal nursing. Never take a blood pressure, never draw blood, and never start an IV in the arm with the fistula. Doing any of those can clot it and destroy the patient's lifeline. You assess it every shift for a thrill, the buzzing you feel, and a bruit, the whooshing you hear. Thrill and bruit mean it is working. 2 more high-yield points. Weigh the patient before and after every session, because the weight change is how you measure the fluid removed, and fluid gain between sessions is the key metric you teach them to limit. And for peritoneal dialysis, the effluent, the fluid you drain out, should be clear. If the drained fluid comes back cloudy, that is peritonitis, an infection of the abdominal lining, and it is reported and treated immediately. Clear is good, cloudy is an emergency. Your patient never needs dialysis. Her kidney recovers because the injury was caught early, by that falling urine output in the very first hour. But not every kidney problem is about failure. Sometimes the filter itself springs a leak, and what leaks out tells you exactly what is wrong. That is Chapter 6. Chapter 6. The leaky filter. The glomerulus is a filter with a specific pore size. It is supposed to let water and small waste through, and hold back big things like protein and blood cells. When that filter is damaged, it splits into 2 patterns, and the difference is what leaks. Nephrotic syndrome, the filter becomes too leaky to protein, so massive amounts of protein pour into the urine. The blood loses its protein, so fluid leaks into the tissues. And the patient swells, badly, with severe edema and a low blood albumin. Nephritic syndrome is inflammation of the filter, so it leaks blood. The hallmark is blood in the urine, often cola-colored, with high blood pressure and only mild protein. Nephrotic leaks protein and swells. Nephritic leaks blood and hypertension. That one distinction answers nearly every glomerular question. The patient's filter is intact, she is not leaking protein or blood. Her kidney was simply starved, then poisoned, and it is healing. But the most common reason a person ends up seeing a nurse for their kidneys is not failure, and not a leak. It is an infection, and where that infection sits changes everything. That is Chapter 7. Chapter 7. Infection. A urinary tract infection usually starts low, in the bladder, and stays local, burning with urination, urgency, frequency, and lower belly discomfort. It is uncomfortable, but it is not dangerous, and it is treated with antibiotics and fluids. The problem is when it climbs. If the infection travels up the ureters to the kidney itself, that is pyelonephritis, and now it is systemic and serious. The tell is the combination. The bladder symptoms plus a high fever, chills, and flank pain, pain over the back at the kidney. A UTI with a fever and flank pain has become a kidney infection, and that patient can go septic. The teaching prevents the whole chain. Wipe front to back, especially important in women because the urethra is short. Drink plenty of fluids to flush the system. Urinate after intercourse. Do not hold urine for long periods. And in older adults, remember the twist that the exam loves. A new confusion or a sudden change in mental status may be the only sign of a urinary tract infection. In an older patient, new confusion means check the urine. Pause. An older adult with a known urinary tract infection now has a temperature of 39, shaking chills, and pain over the left flank. What has happened, and what is the priority? The infection has climbed to the kidney, this is pyelonephritis. The fever, chills, and flank pain on top of the bladder symptoms are the tell. The priority is to recognize the systemic infection and act, obtain cultures, start the ordered antibiotics promptly, give fluids, and monitor for sepsis, because a kidney infection can seed the bloodstream. Treating this as a simple bladder infection is the trap. Our patient has no infection. But she does, briefly, have the fourth and last way a kidney system fails, something physically in the way. And that category, obstruction, is the one that produces the worst pain most nurses will ever see. That is Chapter 8. Chapter 8. Obstruction. A kidney stone is a hard crystal that forms in the kidney and then tries to travel down the ureter, and the ureter is narrow. When a stone lodges, the pain is sudden, severe, and comes in waves, renal colic, classically radiating from the flank down toward the groin, often with nausea and blood in the urine. The nursing priorities are simple and high yield. Control the pain, it is genuinely one of the worst pains there is. Push fluids to help move the stone, unless contraindicated. And strain all urine, so the stone is caught and can be analyzed to prevent the next one. Pain, fluids, strain. The other common obstruction sits at the outlet. In older men, the prostate surrounds the urethra, and as it enlarges with age, benign prostatic hyperplasia, it squeezes that urethra and blocks the flow. The symptoms are all about a struggling stream. A weak stream, difficulty starting, dribbling, and getting up all night to urinate, and worst, the inability to empty, urinary retention. That retention is a postrenal problem waiting to happen, and it is why a distended bladder that will not drain is escalated. The pipe at the bottom is blocked. Our patient's obstruction was that one blocked stretch we ruled out early. She has now been through every category: in front of the kidney, inside it, and behind it, a leaky filter, an infection, a stone. Which means it is time to gather the drugs and the diet that protect a kidney, and put them on one map. Chapter 9: Protecting the Kidney. First, do no harm, because the kidney is easy to poison. The nephrotoxic drugs to respect. NSAID. Pain relievers, which reduce blood flow to the kidney. Certain antibiotics, the aminoglycosides, and vancomycin, which require monitoring. An iodinated contrast dye, which is why you assess kidney function before a scan. Hydrate the patient and hold metformin per policy around it. When the kidney is already struggling, every drug dose is reconsidered, because a kidney that cannot clear a drug lets it build to a toxic level. And the renal diet, which is really about the jobs the kidney can no longer do. Restrict sodium, to control fluid and blood pressure. Restrict potassium, because it climbs and it kills. Restrict phosphorus, which rises and pulls calcium from the bone. And protein is individualized, not a blanket rule, sometimes limited, but for a dialysis patient often increased, so do not teach one fixed protein instruction for every renal patient. And 2 supportive treatments straight from the 6 jobs. Erythropoietin, given to treat the anemia the failing kidney causes. And phosphate binders, taken with meals, to control the phosphorus. Pause and select all that apply. A patient with chronic kidney disease is learning about their diet. Which instructions are appropriate? Limit high potassium foods like bananas and oranges. Restrict sodium. Take phosphate binders with meals. Eat a high potassium diet to replace losses. And follow one standard high protein diet. Limit high potassium foods, restrict sodium, and take phosphate binders with meals. A high potassium diet is dangerous in kidney failure. Potassium is the emergency. And there is no single standard protein rule. Protein is individualized. And a dialysis patient may actually need more, not less. When a question offers a blanket protein instruction for renal patients, it is usually the wrong answer. Chapter 10: Put it together. Every renal decision fits the same 6 questions the next generation NCLEX is built on. What is happening? Recognize the cues. Why? Which of the 6 jobs is failing? Which finding matters most? And in renal it is almost always the potassium or the fluid status. What could I do? What do I do first? And did it work? Is the urine output coming back? Is the potassium coming down? Read the 6 jobs, and every finding has a home. One last patient, unfamiliar on purpose. A man is admitted after 2 days of vomiting and diarrhea with almost no intake. His blood pressure is low, his heart rate is high, his urine output is tiny and dark, and his BUN is elevated out of proportion to his creatinine. Take a moment with that before I say anything else. Walk it. What is happening? Low output, low pressure, high heart rate. After major fluid losses. Why? He is severely volume depleted, so blood flow to the kidney has dropped. This is prerenal AKI. The problem is in front of the kidney. The clue that seals it, the BUN rising out of proportion to the creatinine, is the classic fingerprint of a prerenal state. Which matters most? Restoring the volume. What first? Intravenous fluids to restore perfusion and treat the cause. Fix the flow, and this kidney recovers, but leave it starved and it becomes intrarenal damage. Everything you needed was in chapters 1 and 2. If you keep 5 things from this course, keep these. 1. The kidney does 6 jobs, and every finding in failure is one of them not getting done. 2. Classify AKI as prerenal, intrarenal, or postrenal because the treatment depends entirely on which. 3. Hyperkalemia is the emergency, and calcium protects the heart first. 4. Never take a blood pressure, draw blood, or start an IV in a fistula arm. 5. Urine output falls before the other vital signs move, so it is your earliest warning. And back to where we started. A woman in a bed for something else, her urine output falling, 60, 40, 25, 10, every other vital sign normal. You had no framework for that at the start. Name what is most likely happening. And the single most important early action. A developing acute kidney injury and the falling urine output is the earliest sign, appearing before the blood pressure, the heart rate, or the labs move. The single most important early action is to recognize it and find the cause. Is it in front, inside, or behind the kidney? Because that answer decides everything that follows. Fluids for prerenal, stop the toxin for intrarenal, relieve the obstruction for postrenal. Same falling column. A nurse who acts in hour 1 instead of hour 4. That is the kidney. Not a mysterious organ, but 6 jobs, and a machine that either does them or does not. There are over 1,000 free study guides at clinicaljudgern.com. No paywall, no catch. If this helped, like it, share it with someone in your cohort, and tell me which system to build next. Educational content only, not medical advice. Go be the nurse who catches the urine falling in hour 1.